Today we're going to be talking about clients with peripheral vascular disorders. This is going to be your terminology for this week, and this is also going to be loaded on your guided notes. A couple different factors here that are going to determine your blood pressure, and that's going to be your cardiac output and your systemic or your peripheral vascular resistance. So the cardiac output is going to be the volume of blood pumped by the heart per minute. Blood pressure rises as the heart contracts during systole, thus ejecting the blood. This pressure wave or systolic blood pressure is what you're going to feel as the peripheral pulse in your patient during your assessment. And in healthy adults, this should be about 120 or less. During the diastolic period, or the cardiac relaxing and filling stage, the elastic arterial walls maintain a minimum pressure. That's the pressure required to keep them open. The diastolic pressure to maintain blood flow through the capillary beds. The average of this is going to be about 80 or less. To get patient's baseline, you must have the arm position at the level of the heart and take BP in both arms. I know we often don't do that, but that's the proper way to measure it. The pulse pressure is going to be the difference between the two, the difference between the systolic and the diastolic. And the MAP is going to be the mean arterial pressure, and that's an average pressure in arterial circulation through the cardiac cycle. We started using MAP a couple of years ago to help determine high risk during sepsis. So it's a great indicator of perfusion. When we're talking about a decrease in blood pressure, that is going to be caused by a decrease in cardiac output. For example, hemorrhage or dehydration, or a decrease in peripheral vascular resistance, systemic vasodilation from medications, that will also cause a blood pressure to decrease. While the opposite occurs to increase your blood pressure through increasing cardiac output, example of this is going to be exercise or activities and increasing peripheral vascular resistance with medications as well. Pulse pressure is going to be the difference between the systolic and the diastolic pressure. That's normally going to be about 40 millimeters of mercury. And a high pulse pressure may be a strong predictor of heart problems, and especially in the case of older adults. If your pulse pressure is greater than 60, it's going to be considered a risk factor for cardiovascular disease. Generally, a pulse pressure greater than 40 is abnormal. A pulse pressure lower than 40 may mean you have poor heart function, while a higher pulse pressure may mean your valves are leaky. So that's going to be your valve regurgitation. MAP, just to talk about that a little bit more again, mean arterial pressure, that's the average pressure in the arterial circulation through the cardiac cycle, and that's calculated using a formula. Right now at Unity Point, Epic will do that for you, but it's going to be your systolic blood pressure and your diastolic blood pressure that are going to be used in that formula. So here's going to be the formula to calculate that. Some places will not have their charting system automatically do this, so it's going to be up to you as the nurse to calculate this. And MAP is often used as a surrogate indicator of blood flow and believed to be a better indicator like what I was talking about before with tissue perfusion, other than the systolic blood pressure, as it accounts for the fact that 2/3 of the cardiac cycle is going to be spent in the diastolic area. So a MAP of 60 or greater is believed to be needed to maintain adequate tissue perfusion. Right now, one of the markers, the indicators for sepsis, is going to be a MAP less than 65, but if it's going to be like 63, 64 in that range, they're going to look at the big picture and see what else is going on with the client. Makes a big difference if it's 63 versus, 20. You got to look at your patient and do your patient assessment. Here we've got a couple different things that are going to cause an increase in your blood pressure. So the sympathetic nervous system stimulation, a drop in the MAP, the mean arterial pressure, is what's going to stimulate this. It's going to increase heart rate and cardiac output as well as constriction of the arterioles. And this causes a rise in your blood pressure, and the vice versa is going to happen if your MAP is decreased. So it does work both ways. Epinephrine and norepinephrine, that's going to be your fight or flight response, and that has the same effect as the CNS stimulation. Renin, angiotensin, aldosterone system responds to renal perfusion. A renal perfusion drop stimulates renin release. So renin, angiotensin 1, angiotensin 2 in the lungs by angiotensin converting enzyme. So that's going to be your ACE. Angiotensin 2 is a very potent vasoconstrictor, and this also promotes water and sodium retention by both directly and by stimulating the adrenal medulla to release aldosterone. Lastly, ADH again. I know we've talked about that before when we were in endocrine. So the posterior pituitary promotes water retention and vasoconstriction when stimulated by the release of ADH, and that's going to help increase your blood flow as well, increase your blood pressure as well. Vasodilators, we're looking at the opposite. We're looking to decrease the blood pressure. We've got a couple hormones here. We have ANP, and that's going to promote water excretion and decreasing your blood pressure. And this is a good graphic to help you understand peripheral vascular resistance and how the blood pressure is maintained. So that's the pressure going to be excreted by the blood to keep the vessels open. We want that pressure to be around 80. Primary hypertension, this is also going to be known as essential hypertension. So you may see on boards they might use this interchangeably. The same thing with hospital documentation. There is really no identifiable cause with this, so the cause is going to be unknown. And it's defined as having a systolic blood pressure of 140 or higher, or diastolic of 90 or higher. So those two criteria. This is going to be based on an average of at least 3 or more readings. So one reading alone is not going to be a diagnostic indicator of that. Some people do suffer from white coat syndrome, so their blood pressure is going to be elevated. That's when they come into the physician's office. That's why you want to make sure that you're taking at least 3 values or more. And hypertension is a very huge public health concern as well as a global issue. It's a major risk factor for coronary artery disease, heart disease, stroke, and renal failure. So some pathophysiologic causes of this. The CNS overstimulation can lead to vasoconstriction and increased cardiac output, so that's one possibility. Alterations of renin, angiotensin, aldosterone system, and that affects vasomotor tone and salt and water excretion, even if it's not needed at the time. Chemical mediators can also affect this. They affect vasomotor tone and sodium and water excretion. And excess insulin has several effects that contribute to high blood pressure, including sodium retention of the kidneys, increased sympathetic nervous system causing constriction, as well as hypertrophy of smooth vascular muscle. Can also affect changes in the ion transport across the cell membrane. The result of these causes is sustained increase in blood pressure and peripheral vascular resistance, which the body reacts by causing vasoconstriction or hypertension. It is unlikely that there's going to be one primary cause or pathological process to account for primary hypertension, but rather a group of mechanisms that are going along with this. So think about primary as it's not due to a secondary disorder, which we'll be talking about secondary in a little bit, and that might make more sense to you. So secondary is going to be caused by another disease process. Primary is hypertension alone. Primary hypertension manifestations. Initially, in the beginning of this, these patients are going to be asymptomatic. Headache is going to be usually in the back of the head, and it may be present on awakening and subsiding through the day as the blood pressure lowers. Other symptoms result from target organ damage, and examination of the eye may reveal issues as well. So a lot of times when you go into the eye doctor, they're looking in the back of your eye and the retina, they can tell if you've got some essential hypertension and organ damage going on. They can also be looking at some hemorrhage back there and exudates in the back of the eye. Complications from primary hypertension. The workload of the left ventricle really increases, leading to ventricular hypertrophy, which increases the chances for coronary heart disease, dysrhythmias, and heart failure. You could have some neurological issues such as stroke. Think about the patients that you might see later on, and when you go into the hospital that have a stroke and their only pre-existing condition was that they had a blood pressure of over 200. So that can really cause some significant issues with stroke. The renal system, renal insufficiency or renal failure. And how do you know the kidneys are being affected? So when you're doing your test and your screening, you're going to be looking for protein in the urine, microscopic hematuria. So when you do a UACNS, you might see an increase in RBCs, as well as chronic renal failure. So you're going to be checking your creatinine levels to make sure that they're normal as well. Risk factor, age. So this typically is going to affect the middle-aged adults and older adults. Race, significantly increased in African Americans. So approximately about 40% of African Americans are hypertensive, whereas less than about 30% of Caucasians and Hispanic people are affected. So family history, 40% of people have a genetic link to hypertension. Sodium intake increases fluid retention. So think about people that are always putting salt on everything. Low potassium, calcium, and mag are also contributed to high blood pressure, but it's really unknown on why that happens. And centralized obesity, so fat deposited in the abdomen. Insulin resistance, because of the effects on the sympathetic nervous system, we kind of touched on that already. And alcohol, but it's really more than 3 drinks a day. So 1 glass of wine is actually beneficial for your heart, but it's when you start consuming more than that there's going to be an issue. And of course, stress. If you're stressed out, your blood pressure is going to be higher. So do some deep breathing before the exam and lower that blood pressure. Management of this we're going to be focusing on reducing the blood pressure to 120/80, so that's going to be our target goal. And ultimately, the goal is to reduce cardiovascular and renal morbidity and mortality. So we want to help improve people's lives, help them live a longer and healthier lifestyle. And they really should be checking a blood pressure on every visit to the physician. Lifestyle modifications. We want to encourage weight loss with these patients. Dietary changes, so follow the DASH diet, and that's a dietary approach to help stop hypertension. Eat a rich diet in fruits, vegetables, low-fat dairy products, reduce the sodium, and reduce the intake of total cholesterol and saturated fats. Again, you're going to restrict alcohol. You're going to recommend less than, try to get them to drink once a day, like 1 glass of wine a day as opposed to 3 beers. Again, easier said than done. You've got to make compromises with these patients. Somebody that drinks a case of beer a day all of a sudden isn't going to just drink 1, so maybe they can slowly get there over time. Same applies to cigarette smoking. There are good resources in just about every state. There's usually a quit line and websites that will help you with quitting smoking. Increased physical activity. Physical activity should be about 30 minutes minimum of aerobic exercise on most days. And that's going to really help with the weight loss as well as the stress reduction down here. And there's a lot of different tips on stress reduction. Exercise is going to be a big one. Whatever works for your client. So I would just ask them what they like to do for fun and go from there. Medications. So there's a lot of them. We've got some diuretics, beta blockers, the list goes on and on. We're going to talk about each one of these individually. Diuretics, we've got hydrochlorothiazide. You're also going to see this abbreviated as HCTZ. And then you're going to have the Lasix, the furosemide. The adverse effects with these are generally dose-related and can include hypokalemia. So you want to make sure that you're monitoring those labs, looking out at their potassium levels. Can also affect changes in serum glucose, LDL, triglycerides, and uric acid. This is going to be the first line of treatment, especially the HCTZ. So the American Heart Association, they recommend starting with hydrochlorothiazide before moving to any other for the treatment of hypertension. And just think about what your normal potassium levels are with these and how much your dose is. So some of these patients are going to be taking these in the hospital, especially IV with the furosemide. So you're going to want to make sure that you're monitoring their electrolytes. Other things to do with these, depending on the dose and how often you're giving this diuretic, you're going to be assessing for edema. You want to weigh your patients every day and really give these in the morning. I think it's really cool when people give them late in the day, because then they're going to be up all night using the bathroom, because it is going to cause an increase in urination. And along with that, make sure you're monitoring their I&O. Beta blockers, got a couple here, and they all end, I'm not sure how far you've gotten yet in pharmacology, but they all end in OL. That's one of the ways that you can use to remember that. So nursing indications, you're going to assess for any contraindications with these medications, and that's really going to include your asthma and your lung disease and bradycardia. So the patients with those types of issues should not be taking beta blockers. Assess for blood pressure and an apical pulse before giving these. A lot of times you will have the CNA come in and take the blood pressure for you in the morning, and if they do that at 7 o'clock and you're giving this medication at 9, you should be taking that blood pressure again before giving it. You don't want to be the nurse that gives it anyway and ends up calling a rapid response on your patient and come to find out their blood pressure's tanked. Educate your patients, change positions slowly to prevent any dizziness and falls, because it really does decrease the sympathetic nervous system, and that can lead to some orthostatic hypotension. If they're diabetic, check their blood sugars more frequently, and they should not be stopping their beta blockers suddenly, because it can cause an intense and frequent angina. So if they need to stop taking them for whatever reason, their physician needs to be a part of that. And if I didn't say it already, in regards to individuals with lung disease, beta blockers can cause some bronchospasms, and that's especially true in patients with a history of asthma. Central acting symphylytics, can't speak today. So we've got some Aldamet and some Catapres or Clonidine. We do go by the generic names for boards, just an FYI. Adverse effects with these are going to be dry mouth, some sedation, severe reflex hypertension if discontinued suddenly. So these patients should not be they should be weaned off of these if they're going to change to something else. Administer doses at bedtime, and that's to minimize the effects of sedation. If they're going to be tired, they're going to sleep anyway, and are contraindicated during pregnancy and liver disease. Some of especially this one right here, this one is also available as a patch. So they could be taking it once a week with a patch, and then just make sure that if that's the case, that they're taking the old patch off before they put the new patch on. Vasodilators, that's going to be your hydralazine and your minoxidil. These are going to relax vascular smooth muscle and decrease peripheral vascular resistance. Some potential side effects of this is going to be reflex tachycardia and fluid retention. So your nursing implications are going to be to assess your blood pressure and pulse before giving this again. Instruct your client to change position slowly. report peripheral edema, and any manifestations of fluid overload and heart failure. So again, weigh your patients every day, keep an accurate INO. A lot of the interventions for that's going to be the same. ACE inhibitors. So this is going to prevent vasoconstriction and sodium and water retention. These medications can be used for other disorders other than hypertension. A lot of times you'll see diabetics that have a normal blood pressure. They'll put them on an ACE inhibitor to help protect the kidneys. These adverse effects with these, the most important one's going to be your first dose hypotension. So if you're going to be the first person giving this dose, you really need to be monitoring their blood pressure again in about 30 minutes to an hour to make sure that they don't have any hypotension, and again in another 2 hours after that. That's just usually a standard which I go by. Other things, persistent cough and hyperkalemia. So with the persistent cough with these, you really want to monitor that because it can get quite annoying. Nursing implications: administer 1 hour before meals, instruct client to change position slowly. Don't take a potassium supplement with these unless you're directed by the physician. You're going to monitor kidney function, and if there's any issues with that, any issues with the kidneys, they can take an ARB instead, which we'll talk about here in just a minute. And monitor that patient very closely after that first dose because it really does have the potential to cause some drastic hypotension. The other thing is with the cough, if they end up having a persistent cough, my husband was placed on this medication because he's diabetic, and he started having a cough, and it just doesn't go away. It's constant. So we had him contact his doctor, and they put him on an ARB instead, and the cough was gone. So just be aware of that. Speaking of ARBs, so these are angiotensin receptor blockers, and they prevent vasoconstriction and sodium and water retentions. We've got our losartan, our Cozar, and our Diovan down here. And the adverse effects of these are going to be kind of similar to ACE inhibitors, but these are going to be taken if you have kidney issues. I really don't see a lot of patients having the cough from this, though. This is what they switch them to if they've got the cough. Calcium channel blockers, these relax arterial smooth muscle. This lowers peripheral resistance through vasodilation. That's your diltiazem, your cardizem, nifedipine, or Procardia. The adverse effects for this, again, are going to be reflex tachycardia, and that's going to worsen in patients that have heart failure. Nursing indications, you're going to assess your blood pressure, your apical pulse, liver and renal function tests prior to giving PO or IV. These meds can be given IV, and report signs of bradycardia or heart failure to your MD. These medications really have little effect on the veins, so orthostatic hypertension is going to be minimal with these. Nursing diagnosis, ineffective health maintenance. With that, you're really going to be focusing on any type of current behaviors that contribute to hypertension, and you're going to assist the patient in developing a realistic health maintenance plan. Get the patient involved in this. If they don't help you make this plan, they are not going to stick to it. Help the client identify strengths and weaknesses, and risk for non-compliance. So ask your patients the reasons why they're being non-compliant, and listen openly without judging. There's a lot of different reasons why somebody would not take their blood pressure medicine. Sometimes it's just as simple as they can't afford it, and then if that's the case, you can get the care facilitator involved to help you with your patient. Evaluate their knowledge of hypertension. When you're talking about nutrition more than body requirements, assess how much food they're eating per day and what they're eating. It could be that their diet is mostly fine, but that they keep a shaker of salt in their purse and they add salt to everything. But you don't know those kind of things unless you ask them. Sometimes it helps if patients make a food diary, or you could even refer them to a dietitian. For the last one, excess fluid volume, you really are going to be weighing these patients every day while in the hospital. and monitoring their I&O and looking for any type of peripheral edema. When you are weighing them every day, make sure you use the same scale at the same time with the same amount of clothing. And these patients should really be doing the same thing at home. When you're educating for discharge, they should be calling the doctor if they have 2 pounds or more weight gain in one day, or 3 to 5 pounds in 1 week. Secondary hypertension. This is going to be related to identifiable cause, so an underlying process, but this only really presents in about 5 to 10% of the case, and kidney disease is going to be the most common here. So kidney disease is going to be any disease that affects the renal blood flow, renal artery stenosis, glomerulonephritis, renal failure, and so on. Coarctation of the aorta. See, even sometimes I have a hard time pronouncing things. So it's coarctation of the aorta, and that's going to be a narrowing of the aorta. Endocrine disorders, Cushing's syndrome, SIADH, adrenal medullary tumors, hyperthyroidism, and other pituitary disorders. I couldn't find a good icon, so I just left the kitty in there. Neurological disorders such as increased intracranial pressure and a spinal cord injury. Drug use, and this can be legal and otherwise, so estrogen, oral contraceptives, and that is by primarily causing sodium and water retention. Stimulant drugs, the illegal kind, like cocaine and methamphetamines, and then of course pregnancy. Patients can get hypertensive during that. Hypertensive crisis, so that's going to be your malignant hypertension, and the reasons for this are not exactly understood, but these patients develop a rapid and significant elevation in systolic and diastolic pressures, and this is a hypertensive emergency, and that's why they call it malignant hypertension. The systolic blood pressure on these is usually greater than 180, and the diastolic is higher than 120, and that occurs quite rapidly. Interventions for this, they should be immediate, and you should be treating them in about 1 hour, and the treatment is vital to prevent cardiac, renal, and vascular damage, and that really reduces mortality and morbidity. It can cause papilledema, which is swelling of the optic nerve, and that most often occurs when clients suddenly stop taking their hypertensive medications or they're poorly controlled. Think about these with your women that are pregnant, like your preeclampsia. A lot of times that's when you're going to see that hypertensive crisis. Your manifestations for this are going to be headache, confusion, the edema again, a blurred vision, restlessness, and motor and sensory defects. Your treatment for this is preferably going to be IV. So you're going to be targeting with some different medications listed here, and really the goal is to reduce this no more than 25% in the first hour. So you don't want to drop that blood pressure too quickly with these. And they may or may not be giving these depending on the severity and what is the cause of the hypertensive crisis. Your nursing care, you're going to be continuously monitoring their blood pressure, so that way you know if they're responding to the treatment. Titrating the medications, that's very important. So every time, you're not going to be doing this quickly, so you want to reduce their blood pressure slowly over time. So you're going to be in there monitoring them, taking their blood pressure, and then titrating those. Again, avoid a drastic change in this, no more than 25% in the hour, and then you're moving towards 160 over 100 in about 2 to 6 hours. So the higher it is, the longer it's going to take to control that. And then you're going to calmly reassure these patients. They're very nervous. They feel cruddy from the high blood pressure, so you're going to reassure them. In peripheral vascular disease, we've got a hardening and a narrowing of the peripheral arteries, as you can see right there. This is going to impair blood supply to peripheral tissues. Generally speaking, when this occurs, the collateral circulation is usually inadequate. So if you think about the blockage being right here, is there really going to be enough blood flow around that to help perfuse that leg? So what ends up happening is circulation of blood through a network of minor vessels. These become enlarged and joined with adjacent vessels when a major vein or artery is impaired. So if this is impaired, the other ones around it are going to start to compensate for it. This is usually caused by atherosclerosis. We've got these fat deposits and fibrin, and these obstruct and harden the arteries. Usually this affects people in their 60s and 70s, and men are more affected than women are. This is going to be a good example of intermittent claudication. So the pain is going to be a primary symptom of this. It's going to be cramping or aching pain in the calves or legs. It can go up to the thighs and the buttocks as well. And this occurs with a particular level of activity and is characteristic of PVD. So they start to walk, and after a block or two, they start to get that pain in the leg. As soon as they rest, that pain can go away. Alternatively, they can also have rest pain, and this is characterized by a burning sensation in the lower legs. And this really decreases when the legs are dependent. So if they're having pain with their legs elevated, sometimes that does happen, we as nurses want to elevate the legs, and come to find out that ends up causing them more pain. So you lower their legs, and all of a sudden the pain subsides a little bit. They could have diminished or absent peripheral pulses. If you cannot find a pulse on these patients, try to dorsiflex the foot and then try to get a pulse again. You may end up having to Doppel that area. Along with this, they're going to have quite a bit of power with extremity elevation, and dependent, it's going to be quite red. So they're going to have rubor, dark red when dependent. Looks like I just got a little ahead of myself on the slide. So this is just talking about when the pain occurs and when it decreases. This is just another picture of the different manifestations that I'll go over on the next slide. So with their skin, it's going to be often shiny and hairless with discolored areas, and we can really see that there. There's no hair on this leg, and it's got the discolored areas. Their toenails may be thickened. Can't really see that on that picture, but you will see an increase in that. And then areas of skin breakdown may be present along with edema, and we definitely see that in this picture. They're going to have an increased risk for neuropathy, and then the ulcers, they really don't heal that well. Other complications of this can include gangrene and extremity amputation, rupture of abdominal aortic aneurysms, and sorry, my slide just kept jumping, and the possibility of infection and sepsis. Risk factors, other risk factors include inactivity. Activity is going to help promote the development of collateral circulation, so circulation around the area that is affected, and maintain tissue perfusion. So other risk factors are going to be diabetes, high cholesterol, hypertension, cigarette smoking, high homocysteine levels, but that could be due to a genetic relationship too. So sometimes these people are predisposed because of genetics. High homocysteine levels. Most people who have high homocysteine levels don't get enough folate, folic acid, vitamin B6, or vitamin B12 in their diet. So high homocysteine levels in the blood can damage the lining of the arteries. In addition, these levels can also make the blood clot more quickly. For these patients, we can do segmental pressure measurements, and that's when we take a blood pressure cuff and a Doppler device to compare blood pressures between the upper and the lower extremities. And you're usually going to see a decrease on the lower extremity. Stress test, they're going to have the patient get on a treadmill, and that provides a functional assessment of their limitations. In PVD, the pressure at the ankle may even decline even further during exercise. Doppler ultrasound, that's going to affect the blood flow. And then a contrast angiography, they're going to instill a contrast medium in the vessel, and that's going to be used to locate and evaluate blood flow. Drug treatment of peripheral atherosclerosis is really a lot less effective than it is going to be with coronary artery disease. They're going to give medications to inhibit platelet aggregation and reduce the risk of arterial thrombus, and that's going to be your aspirin and your Plavix. Pledol, that is a platelet inhibitor with vasodilator properties, and that's going to improve claudication in those patients. The Trental decreases blood viscosity and increases RBC flexibility, so it kind of helps get the RBCs through the obstructed area. This increases blood flow to the microcirculation and to the tissues of the extremities. And then lastly, the parenteral vasodilator prostaglandins, those may be given on a long-term basis to decrease pain, help facilitate healing with individuals with severe limb-threatening ischemia, so the ones that are going to be at risk for losing a limb. Management with these patients focuses on slowing the atherosclerotic process and maintaining tissue perfusion. So you want to maintain that limb. Smoking cessation is really going to be essential with that. A lot of these patients do smoke, so you want to help encourage them to quit smoking, and that will help to save that limb. Smoking not only promotes atherosclerosis, but it can cause vasospasms as well, and this further decreases blood flow to the extremities. Foot care, educate your patients on proper foot care. Exercise, so you want to encourage them to have regular progressive strenuous exercise. That's very important with these patients. In the beginning, you could have them start off small and just kind of increase it from there, and then controlling their modifiable risk factors. Some of these are going to be disease management with other things like hypertension, diabetes, and you want to really focus on slowing the atherosclerotic process. So they can't control that they have diabetes, but they can do things to help control that disease, and that will reduce the chances of complications. Some of the complications you're going to see are going to be gangrene. They could have rupture of AAA, which is an abdominal aortic aneurysm, infection, and sepsis. And when you think gangrene, think limb loss. They could be losing their limb as a result of this. Nursing diagnosis for these are going to be ineffective tissue perfusion in the peripheral, pain, impaired skin integrity, and activity intolerance. And we're going to go over some nursing considerations in a few slides for these. This is one of the ad campaigns targeted at smoking with peripheral vascular disease. Those toes are probably going to end up coming off. And what ends up happening with this, here I'll show you a different picture. So this is a good example as well of PVD. Chances are this patient just went untreated for a long time until the symptoms got so unbearable, but that toe is not salvageable, so they're going to end up having to amputate that. And what ends up happening with them after they discharge, they keep participating in their lifestyle choices. They don't really change anything, and you can see over here the toes are gangrenous as well, and they just it keeps moving up and up and up until they end up with a below the knee amputation or even above the knee. And statistically speaking, if you have an above the knee amputation with all these other comorbidities, you probably won't ever walk again. It's quite traumatic. There's another example of this. See how much that area is affected. It's hard to say what's going on this side, but I bet you it's some type of venous stasis ulcers over here. A couple different surgeries are going to be targeted at revascularization of the area, and one of those is going to be your percutaneous transluminal angiography. During that, they're going to be going in, it's like an angioplastic procedure. They will go in through the groin and they will place a stent, or they will do an angioplasty, just depending on the severity of the issue. And a percutaneous transluminal angiography with a stent placement, that's considered a non-surgical intervention, or even an atherectomy. So that's when they're going to be moving the atherosclerotic areas. They can also do balloon angiography to dilate the narrowed lumens, mechanical atherectomy to remove the plaque, or laser or thermal angiography to vaporize the occluding material. A stent can be placed then to maintain vessel patency after that. Surgical procedures are going to be these last two. Sorry, that was bugging me. So an endarterectomy is going to be a removal of the occlusive plaques from the artery, and then a bypass is going to just go around that area. These come with a higher risk of post-op complications as well. When I upload the actual PowerPoint, you should go to, let me see if the link is on there. Go to that link and watch that procedure. An arthrectomy is going to utilize a catheter with a sharp blade on the end of it to remove plaque from the blood vessel. The catheter is inserted through an artery through a small puncture. That oftentimes is done in the groin. Sometimes they can be under local anesthesia with this, but they're not going to completely sedate the patient. The catheter is designed to collect and remove plaque in a chamber in the tip, which allows for removal of the plaque when the device is removed from the artery. So it collects it before it leaves the body. The process can be repeated at the time of treatment is performed to remove a significant amount of disease from the artery, thus eliminating the blockage and any atherosclerotic disease. Complications from this is going to be embolisms, so dislodgement of the debris that blocks the arteries, and that can really cause quite a bit of complications. This procedure shows an endarterectomy, and that's going to remove occlusive plaque from the artery. With these, they have a higher incidence of stroke, MI, infection, and clots. These procedures can be done in all sorts of arteries, even in the carotid, so they'll do like a carotid endarterectomy. This one happens to be in the leg. So it's a pretty delicate operation. It can require several hours. The surgeon makes an incision over the blocked artery and then inserts a tube above and below the blockage, and that redirects the blood flow while the artery is being opened. Next, the surgeon removes any fat and cholesterol buildup, along with any blood clots that may have formed, and then with a blunt dissecting instrument, kind of moves along from there. So they bathe the skin with a saltwater solution that's combined with heparin, which is an anticoagulant. The surgeon then stitches the artery just enough so that the bypass shunt tube can be removed, and then they stitch the artery completely closed. After they make sure that there's no blood leaking, they then close the incision with stitches. So it's pretty time consuming. This is going to be a bypass graft, and that's a surgical procedure to redirect blood flow around an area of blockage. This procedure creates an alternative channel for blood flow, bypassing an obstructed or damaged vessel. The graft itself can come from the patient's own vein, or synthetic material such as Dacron can also be used. If it comes from their own vein, just make sure that you're assessing both incision sites. So it could be coming from the arm, it could be coming from the other leg. Most likely with peripheral vascular disease, it's not going to come from the other leg. Usually both legs are going to be affected. After these procedures, you're going to be frequently monitoring and assessing peripheral pulses. What do you do if you cannot feel these pulses? Sometimes these patients, even before they've had the procedure, you cannot palpate a pulse. You're going to use the Doppler. You're going to help control their pain, assess for color, temperature, cap refill, position their extremities dependently, add a foot cradle, and that is just basically kind of looks like a rainbow shape, and it hooks onto the bed, and that keeps the blankets up off the bed so it's not weighting down on their limbs. And then for frequent position changes for them as well. Venous thrombus is also going to be referred to as thrombophlebitis, and that is a condition in which a blood clot or a thrombus forms in the wall of a vein, accompanied by inflammation of vein wall and some degree of obstruction from venous blood flow. A venous thrombi is more common than an arterial one because there's lower pressure and flow in the venous system. These thrombi can occur in superficial or deep veins and causing a deep vein thrombosis. DVT is going to be the most common one, and that's going to be in the calf. About 80% of those DVTs are going to be in the calf. There's three pathologic factors called Vischow's triad, and they're associated with thrombophlebitis: the venous stasis or sluggish blood flow, vessel damage and trauma from inflammation or injury, and increased blood viscosity from altered blood coagulation. Vessel trauma stimulates the clotting cascade, and then platelets aggregate at the site. This is especially true when venous stasis is present. And you got to think about when venous stasis is going to be present with your patient. These patients are going to be the ones that are immobile. Think about the ones that have just had surgery, the ones on bed rest, and so on. And platelets and fibrin will begin the initial clot. RBCs are then trapped after that, and the venous thrombus grows. DVT manifestations, and you can see this picture shows a really good example of that. They're going to have some calf pain, and that's usually occurring when ambulating. It can be described as tight, dull, or aching pain. The blood clot triggers an inflammatory response that creates tenderness, swelling, and warmth, as well as redness. So your patients are going to be very tender. They may also have some cyanosis present on the affected extremity, or even some edema, as we see in this case. A positive Mullins sign is a really poor indicator, and this practice is really controversial because it can really break off that clot and cause a PE. So we do not elicit a Mullins sign anymore in our patients. Superficial may be more localized or tender over the affected area, redness or swelling over the course of the vein, and you can actually palpate a cord over the vein when that happens. Swelling or redness over the surrounding or localized area. So when you see this, you can see there's a pretty significant difference between these two legs. Risk factors for developing DVTs: hospitalization, immobility, abdominal or thoracic surgery, orthopedic surgery. Certain types of cancers can affect the coagulopathy in the body, so some of those patients are going to be really prone to blood clots. Trauma, pregnancy, use of oral contraceptives, and HRT, or hormone replacement therapy. Complications. These patients can have chronic venous insufficiency because of damage occurring to the valves, and that impairs directional flow. PE, or pulmonary embolism, is going to be a major complication, and that occurs when a clot fragments or breaks loose from the vein wall. As the clot travels, it moves through progressively larger veins and into the right side of the heart, then enters the pulmonary circulation with the potential of occluding arterial flow in the lung, and those happen rather fast with very, very little warning. And you can see there's a blood clot right there. Many organizations, including UPH, have prophylactic measures and medications to help prevent venous thrombus when a patient is at high risk. You'll see a lot of low molecular weight heparin being used for patients that are high risk because it doesn't require a whole lot of monitoring. The common term for this is going to be Lovenox, and they're going to be administering the sub-Q 1 or 2 doses a day, and that makes it really easy to give in an outpatient setting. So one of the things that you're going to be doing with these patients, especially if they're going to be discharged to home on this, is to teach them how to administer that to themselves. Other options are going to be oral anticoagulants such as Coumadin. You're going to watch for signs of bleeding with either one of these: dark tarry stools, coffee ground emesis, large hematomas, low blood pressure. You're going to keep vitamin K on hand when your patient is on Coumadin because it is the antidote for that. You're going to be monitoring frequent PT-INRs, going to be daily in the beginning, and then you're going to want that between 2 and 3, which is 2 to 3 times the normal level. Educate your patient on foods that are high in vitamin K and taking the medication the same time every day, which is going to be about 6 p.m. You also want to educate your patients on strenuous activities, reduce of injury, and using a soft toothbrush. You're going to overlap the use of low molecular weight heparin, so you're going to overlap your Lovenox with your Coumadin for about 4 to 5 days, because this is going to kick in a lot faster than the Coumadin does. Coumadin takes about 3 days to start taking effect. And then once therapeutic levels are reached for your Coumadin, once your INR is in range, then they're going to discontinue the Lovenox, but your patient might be on that for about 3 months. There's also a lot of other newer anticoagulants out there, like Arixtra is a good example of that, and those don't require hardly any monitoring at all. And then I want you to think about what non-medication, like what can you do to prevent DVTs that doesn't involve the medication. SCDs, so that's what we're going for. We want to focus on prevention. SCDs, or TED hose even, those are going to be your elastic stockings. So thromboembolic deterrent hose is another name for them, and compression socks. They're also called JOPS socks or JOPS socks. There's a lot of different names for these. Those are used for prevention and to promote increased circulation of blood flow. Other alternatives include elevating the foot of the bed and really early immobilization. So you want to do leg exercises, flexion and extension, and get a PT and OT consult for these patients. That will really help. They will sometimes do surgery to remove a blood clot from a large vein, especially in cases of acute vein occlusion and severe pain. A venous thrombectomy has been known to remove some of the vein lining along with the clot, resulting in an increased risk for repeat clot formation. Various methods to the procedure have improved the success rate. A lot of times what I'll end up seeing with these patients, especially if they can't be anticoagulated and they keep producing blood clots, is they'll put in an inferior vena cava filter. So an IVC filter. I got a picture of it here. So an IVC filter is a small, specially shaped device that's made out of stainless steel or nickel titanium. And that is going to be placed in the inferior vena cava. Excuse me. And that's going to prevent blood clots from traveling to the lower part of the body to the lungs. So it kind of looks like this. It looks like a little teepee. And they just fit it in through the groin, and then it rests right up here. So that way the blood clot, you can see another picture over here, so the blood clot does not travel to the lungs. Treatment for this, for DVTs and clots, anticoagulants to prevent clot propagation and enable the body's own lytic system to dissolve the clot manually, are the mainstay for the treatment of venous thrombosis. For example, Coumadin, heparin, Lovenox, Pradaxa, Xarelto. There's a lot of newer ones that are out there now. Thrombolytics such as streptokinase or TPA, which is going to be your tissue plasminogen factor, those may accelerate the process of clot lysis and prevent damage to the venous valves. NSAIDs can also be used, such as Indocin or naproxen, and that can be used to decrease inflammation in the veins and provide symptomatic relief as well. You can apply a warm compress, a warm moist compress over the vein up to 4 times a day as well. And then bed rest is usually determined by how much swelling is involved. You want to position the patient with the legs slightly elevated 15 to 20 degrees with the knees slightly flexed. And avoid prolonged standing, sitting, and crossed legs with these patients. Nursing diagnosis, pain, you're going to assess pain location, characteristics, make sure that you're measuring the calf or wherever the clot is. I've seen them sometimes happen in the arm, especially if a patient has a PICC line. Apply warm, moist heat at least 4 times a day. Ineffective tissue perfusion, you're going to assess peripheral pulses, capillary refill, skin, and you're going to check the color at least every 8 hours. Elevate legs at all times, knees slightly bent. Use mild soaps and lotions and pat dry. Don't rub the area. Don't massage them because that could make the clot break loose and you don't want them to have a PE. Egg crate the bed if you need it. Encourage frequent position changes. Monitor PT, INR, and H&H. So you're going to keep an eye on their blood. Impaired physical mobility. With these patients, active range of motion exercise, get PT and OT involved with them, intervene early on them. Frequent position changes, deep breathing and coughing, increase fluid and dietary fiber, and assist with ambulation. And ineffective tissue perfusion, you're going to frequently monitor their respiratory status. You want to make sure that you're monitoring for PEs. Chronic venous insufficiency is going to be a disorder of inadequate venous return over a prolonged period of time, and this is going to be the most common cause of a DVT. Venous stasis occurs, impairing arterial circulation. So following a DVT, large veins may be occluded, increasing the pressure in other veins. This pressure distends the veins, damaging the valve's ability to close, and this results in impaired unidirectional blood flow. The venous blood is going to collect and stagnate in the lower legs, the venous stasis causing altered nutrients and oxygenation to cells, and wastes are not removed. So some of the manifestations are going to be with this brown pigmentation, and that's a result of breakdown of RBCs and the congested tissue. And you may even see some edema with that. They're going to have itching, discomfort, possibly cyanosis, shiny atrophic skin, and venous stasis ulcers. You might see those start to develop. I got that listed here twice. So venous stasis ulcers may develop, usually occurring at just above the ankle, and the tissue surrounding the ulcer is typically shiny, atrophic, and cyanotic, and there could be that brown pigmentation that I told you about, which you see it right there. Risk factors for this include DVT, varicose veins, and leg trauma. A couple different medications to treat these. They could give corticosteroids to decrease inflammation, zinc oxide, as well as some antifungal medications to decrease the risk for infections. In Burrow solution, compresses are added to any type of weeping dermatitis 4 times a day for 1-hour periods following corticosteroids. Your collaborative care is going to be focused on relieving symptoms, promoting adequate circulation, and healing and preventing tissue damage. Conservative management focuses on reducing the edema and treating ulcerations. And then large chronic ulcers may require surgery to excise ulcerated tissues and provide skin grafts. Nursing diagnosis, again, with these, disturbed body image, think about the alterations that are happening in their legs. They might be embarrassed to wear shorts. Ineffective health maintenance. A lot of these patients have poor health practices. They aren't taking care of themselves very well, and they waited a long time to get treatment. Increased risk for infection. They've got those open wounds on their legs. You want to promote good skin care. You want to take care of any impaired physical mobility, get PT and OT involved. The impaired skin integrity fits along with the risk for infection. So you're going to be doing your dressing changes, frequently assessing the skin, documenting on those, and performing skin care as per the wound care orders. And then ineffective tissue perfusion peripheral again for this one. So really with these, a couple different examples of what these will look like. This actually, this could have been the same leg even, like before and after wound care treatment, because that wound bed looks pretty pink. You're going to elevate the legs while resting. When sleeping, you want to have the legs positioned above the heart. Walk as much as possible, but avoid standing or sitting for long periods of time. Don't cross your legs. A lot of these patients with venous insufficiencies, you'll come in the room and you'll see them with their legs crossed. Don't wear anything that pinches their leg, and only wear elastic hose as directed. So if the order says to put TED hose on in the morning and remove them at night, make sure you're doing that. Also make sure that those hoses, the TED hose, aren't bunched up and causing pressure wounds. That is the last slide for this section. If you have any questions, as always, make sure you post them to the discussion board. Thank you.